And just so you know, you are actually on the webinar put on by Life and Death Wellness. The topic this evening is called the Our Cure, Our Choice Act, Medical Aid in Dying, a talk story with Dr. Charfen. And that is me, Dr. Charfen. And just to let you know, Life and Death Wellness is a nonprofit. We are founded up in North Kohala, actually, and our mission is around education, that all life matters, but especially the end of life. And so this is part of what we do. Every month we try to have a webinar, and this month happens to be on medical aid in dying. And I'm going to be your host, Dr. Charfen. Just so you know, I'm going to give the presentation, but I am so happy to take questions. This is a topic that people have a lot of questions about. So please feel free to put your questions in the Q&A. I already have some that people send in by email. You can even make it anonymous if you don't want people to know. I'm not going to call you out, I promise. And we are recording this. You can't be seen, you can't be heard. We are recording this so other people can actually take part and watch this later. And so just a little bit about me. My name is Dr. Charlotte Charfen, also known as Dr. Cha-Cha. I am an emergency medicine physician. That is my training. That's my board specialty. I've been working in the field of life and death for about 20 years now. And, I came to the island about 5 years ago, and I knew I was coming for a reason maybe outside of the emergency department. And I didn't know exactly what that would be, but it has really turned into working with patients and their families around a terminal illness or their chronic illness. So I do that outside of the emergency department. I'm always kind of doing that inside of the emergency department. And I'm one of the co-founders of the nonprofit Life and Death Wellness. So the goals of my presentation this evening is to educate you in case you don't know about the law. Education's number one. Okay, that's the mission behind Life and Death Wellness, is to provide education on all kinds of life matters, right? And the other goal is to dispel misinformation about this law. There's a lot. I had a physician just the other day say, "Hey, what kind of special license do I need to prescribe the medication for medical aid in dying?" And I said, "Well, you just need your Hawaii state license." So there's a lot of misinformation. So I'm going to try to dispel that. Identify barriers to the law, because there are so many. And as I go through this presentation, I think you'll see that, and maybe some new ones will come up that I didn't even think about. My goal is not to sway or convince anyone of anything. Okay, this law is absolutely a very personal decision for anyone that goes through it and any clinician that participates in it. And so I'm here to just give you the facts and give you some of my experiences thus far on the island. And people are like, "Well, why are you talking about it?" Well, I actually was the first physician outside of Oahu to write a prescription on any outer island in 2019. And so I have now written 5 prescriptions. Now we do have another physician on our island that's written it, but we only have 2. So anyway, I'm going to continue on. And so death with dignity. A lot of people ask about that and say they think that the law is about, or they think that MAID is the only way for death with dignity. And that's absolutely not the case. Okay. There are many, many ways to die with dignity. And the medical aid in dying law is just actually one of those. Okay. So I want to tell you about this patient. His name is Larry. He is a 55-year-old male. He presented to my emergency department over 5 years ago, complaining of severe neck pain. I hope you guys can hear me. Hold on. I'm gonna, let's see. Okay, I'm going to keep, if you guys can't hear me, please pop up and let me know. My screen just kind of went out. So I'm like, oh gosh, I hope you can hear me, and I hope you can see me. If you can't, please raise your hand and say something. Anyway, so Larry, okay, thank you. You can hear me. Okay. Larry, oh shoot, I'm sorry. Oh, here's Dr. Charfen messing stuff up. Larry, came to me and complained of severe neck pain. And what I ended up doing was scanning Larry's neck, because there was something, I just had a gut feeling that his pain was something more significant, and it actually ended up being something definitely more significant. It ended up being metastatic cancer. And when I went and told Larry his terminal diagnosis, his first question to me was, what do you think of that medical aid in dying law? And I have to tell you, I was very honest with Larry. I told him I didn't know. Because I had never worked in a state that actually had that law. Now, at the time, this was in Hawaii, and we didn't have the law. I had no idea that actually there was even a debate about this law. And Larry just looked at me and he said, you know, I have a friend and he'll take me to California because I will not die a burden to anyone. And then he paused and he said, but I want to die in my home. Hawaii is my home. And so what I said to Larry was, well, have you ever considered hospice? And he really didn't know much about hospice. And so we talked about hospice, and lo and behold, he accepted hospice, and I became Larry's friend. And I will tell you, Larry did die a very dignified death, but it's because of Larry that I got interested in the law, and patients actually started approaching me when the law passed, because I started a nonprofit called Life and Death Wellness. So dignified death, right? Like I just said, there are many ways to have a dignified death, but I would like to say, are these, dignified responses. These are things that I've actually heard, that either my patients have heard them or I've heard them said out loud. Go home and die naturally, or drink a bottle of Benadryl. This sounds like Kevorkian's back. Do you believe in the Bible, or do you believe in the 10 Commandments? I don't do this. I'm not allowed to do this. The hospital policy just doesn't allow this. Our institution takes a neutral stance, so we don't talk about it. Or there's a response that they just completely change the subject altogether, okay? And don't even address the request. And I would say all of these things are not dignified. I mean, it's clear, Dr. Benadryl, right? But even when we're not engaging, or at least trying to understand where that person's coming from, we're not really having a dignified response. So I just ask you to keep that in mind. Okay. Sorry, I'm really trying to make this little thing pop away. Anyway, we're going to be talking about the Our Cure, Our Choice Act. That's what it's called in the state of Hawaii. Every state has a different name for their law, but this is the Hawaii state law. It's called Our Cure, Our Choice. And that means that a terminally ill patient that's got 6 months or less to live can request a prescription from their physician to hasten their death. And that went into effect January 1st, 2019. Okay. We are one of 10 jurisdictions that have this law in our country. The last 6 years, or the last 5 years, 6 have come into law. And so now basically about 20% of the country actually has access to some form of this law. We'll talk about how ours is a little bit different than the others. But I want to make sure you do understand that it's not a common thing that people actually access, okay? Only about less than 1% of people in Oregon that died actually access the law. And I hear a lot of times, oh, well, more people are going to die because of this law. That's actually not true. In order to qualify for this law, you have to be dying. So there's not extra people dying. There's just a few people that are dying with this law in place, okay? The common things you're going to hear, a lot of the reasons why people choose to access this law is loss of autonomy. They're not able to enjoy the things that they once did in their life. Loss of dignity. Those are all very common. I think where people actually get, surprised is they think that the pain control is going to be higher, and it's not. Hospices do an exceptional job in controlling people's pain. So usually, it's on this list, but that's not the reason most people choose this option. And so this is just data from our Department of Health of the people that qualified in both 2019 and 2020. So you can see it's not a lot of people that actually went through this. The 2020 data is not as up to date because, one, we haven't closed out 2020, and this is only through the end of October. But as you can see, really in the first year we had 30, in the second year we had 33, and only about half, or a little bit above half, chose to use the medication. Most commonly, what is cited as the reason or the illness that qualified them is cancer. And what we see with our statistics is that it's people over the age of 65 that are male, that have private medical insurance, interesting enough, and are white. If you look at the data of the other states, that's not always the case. It's usually 50-50 men and women, but I think we're just early on in our law. Okay. And it is taking us a while to get through it. We'll talk about really what are, how long it should be taking. The other thing I just want to point out is there's no duty to participate. Okay. That means physicians don't have to if they don't want to. But if they do, there's no liability. That's what I hear from a lot of physicians. They're really concerned about the liability. As long as they're acting in good faith, there is no liability. There has been no disciplinary action taken against any physician in any state, whether they participated or declined to participate. So how do you actually become eligible? You have to be an adult, like I said. So you've got to be 18. You have to have you have to be terminally ill, right? Meaning you have 6 months or less to live. You must be able to make your own medical decision. So you have to be mentally capable and a resident of Hawaii. You can't be somebody that just came over from another state and said, hey, I'm going to come have a vacation and then access this law. It doesn't work that way. You have to show approved residency. And you absolutely have to be acting voluntarily and capable of self-administering the medication. And there is a misconception here that your family can't help mix the medication. They can. A physician could mix it. Family can mix it. They can hold the cup. What they can't do is turn it up. Okay. You have to be able to either sip from a straw, turn it up, use a peg tube. Some people get, people that have ALS get, they find all kinds of ways. They use the rectum. Okay. So, but you have to be able to do it yourself. And then there's a whole process that people have to go through, right? So there has to be confirmation of the eligibility. And how does that work? So in the state of Hawaii and every other state, it takes 2 physicians licensed in that state to say that you actually are eligible. Now, in our state, that can become a potential barrier. Why? Well, one, we are limited on the amount of physicians we actually have in our state. We're having a turnover all of the time. And so this is a difficult one. And so there's actually some legislation we'll talk about that to hopefully help for that. But anyway, for right now, the way the law is written, there's an attending physician. That's a person that's taken on the most responsibility. Okay, that's the way I've always acted with my patients, the 5 that I've helped. So I oversee the process and I am the one that's responsible for writing the prescription. Then there's also the consulting physician, and that person is it's pretty easy. All they have to do is say they're eligible and they're mentally capable. Where Hawaii is different from any other state is that you also have to have a mental health evaluation. Okay, so other states, they say, well, if either one of those doctors have concerns, they should refer. Our state mandates that somebody get seen by a mental health provider, and that can be a potential barrier for some. 1, because we don't have a lot in our state. 2, if they're not already plugged in, that's just another hoop they have to jump through. Right. And the person has to make basically 3 voluntary requests. Here's another barrier. In our state, again, we're different. In every other state, it's 15 days or less that the patient has to make 2 oral requests. In the state of Hawaii, it's 20 days. And so that means the length is longer. The patient's got to live longer in order to get through it. And there also has to be 1 written request, and that all goes to that attending physician. The other piece that I really appreciate about this law, and this is what got me interested in the law is, there's several things that got me interested in the law, but one was you have to really talk about all of your end-of-life care options. And for me, being an emergency physician who has witnessed what happens when people don't talk, I think this is a wonderful part of the law. So I really spend a lot of time. These are just a list of some of the things that I go through with my patient. And you'd actually I was surprised. I thought anybody that was trying to go through this process would have already had their advance directive and their POLST in place. That's not always the case. So I spend a lot of time making sure that their paperwork is in order, that they are referred to hospice. They don't have to go to hospice, but it is encouraged under the law. And I think it's just good medical practice. So we talk about all of these things, not just medical aid in dying. And so A lot of people want to know about the medication. And I think it's a really important piece to this that the law really doesn't focus on, because that's, the law makes it legal, but they don't mandate what medication is used, because that's changed over the years. As the data improves and we learn more. So there is a best practice, and I'm going to talk to you about that medication, but there can be variations in the medication that's used. Typically, on average, if one certain type of compounded medication is used, it's called DDMA, and I'll explain that in a second. The patient's usually going to fall asleep within 10 to 20 minutes, and they will die in 1 to 2 hours. Now, that's about 90% of cases that have used this specific medication. So there's a 10% gap there. What happens to those people? And I think that's really important. Anybody that's getting involved with this law, especially physicians, really need to know, but so do the patients. Because think about it, if you are a terminal patient, your GI tract in general may not be working so great. And so anybody that has a cancer of the GI tract or whose GI tract has already slowed significantly, they raise a red flag. They may be patients that fall outside of that window. Patients that are really healthy besides their terminal disease. I think of our glioblastoma patients or our ALS patients. They have very strong hearts. People that are obese, who have a history of alcoholism, or anyone that's got a tolerance to opioids and benzos. Most of our hospice patients do. So we really need to understand, I think this is a really important piece of the education for physicians and for patients to know that yes, we have an average of what typically happens, but this is what you can expect. Okay. So I've listed the most common or what we think is the best practice as far as the medication. It's called D-DMA. And basically what that is, it's 2 heart-stopping medications and 2 really sedative type medications that are given in 2 different bottles. So you have to pre-medicate first so you don't vomit. That's what that 1 hour prior is. And then you have to mix a bottle with, usually it's apple juice or whatever the patient really wants. Drink that, wait 30 minutes and take the second bottle. And that's the one that puts you to sleep. And there's a reasoning behind that. We could combine it all, but then that heart-stopping medication wouldn't get absorbed and probably wouldn't work as quickly. So this is kind of where we have found the best practice. I'm going to tell you that second bottle tastes terrible. It burns and it tastes bad. And so there is a real concern around that. I don't think a lot of people tell you that, but it's something the patient needs to know and something the doctor needs to know. What about health insurance? Do they cover this? They're basically, it depends. So if you're in private insurance, like Kaiser, they cover the whole process. They cover all the doctor visits and they cover the medication. If you have Medicare, if you are a veteran, if you have TRICARE, there's actually a federal prohibition against filling the prescription. There's not a prohibition against going through the law. It's not like cannabis where there's a federal mandate, whatever. There's nothing that the feds say that's illegal about doing this act, okay? But they won't cover the medication. And so Medicaid eventually may, okay, cover. So the other thing is just to know that the law mandates that your wills, your insurances can't be affected by your choice in this. On your death certificate, it's your underlying illness. It doesn't say, oh, this patient took medical aid in dying. And the law is very specific. This is not considered suicide, okay? And I want to really go through that because I think there is, this is where I think a lot of people get into their debate. And I'm not trying to change your mind, but I want you to understand what the law says. It's not suicide. It's not assisted suicide. It's not physician assisted suicide. It is not homicide and it is not euthanasia. And why do I say that? And I really, if any of you have been affected by suicide, and most of us in our culture have, think about what that was like when you found out a loved one died by suicide. Okay. So just put yourself there first of all. Okay. And then I want you to think about somebody that's dying. Okay. They're not choosing between life and death or choosing between a death and death, because that's what a medical aid and dying patient is doing. So they have to have a terminal diagnosis, whereas a patient that commits suicide doesn't. They have to be mentally capable to go through this whole process. I mean, that's why all these stops are put in place in the law. Somebody that commits suicide is typically not doesn't usually have mental capacity, whether that's because they have an untreated psychiatric illness or whether they have alcoholism or drug use. So that's the difference there. It's planned in medical aid in dying. This is not, I think a misconception that a lot of people have. They're like, oh, I'm just going to use that pill. Oh, I'm just going to, off myself. It doesn't work that way. This is a very planned thing, one for the patient, but it's also encouraged to be with the family, right? You're going through way more than a 20-day process. So there's constant planning and asking and questioning, which is not what happens with suicide. Right. And usually with medical aid in dying, if all goes well, it's a very gentle, peaceful death. That's not always the case with suicide. Usually suicide can be violent, gunshot wounds, hangings, and the grieving is different. And these are just different associations that deal with suicide, that say medical aid in dying and suicide are just not the same thing. Okay. This was another thing that really caught my attention when I started learning about the laws in other states. Oregon, like I said, has had the law the longest. And what have we learned from Oregon? What we have learned is that their end-of-life care overall has improved, and they do contribute it to this act going into place because it's opened up dialogue between patients and their physicians that wasn't there before. And I can so relate to this because it's so hard. I mean, the conversation itself is so hard for physicians that don't do it often. It's really hard for a patient. And so really, this is really what kind of got me really interested in understanding this law is, oh, wait a minute. So it's not just the patients that actually opt for this law whose lives improve. End of life care in general improves. And the reasons are, even if a physician is not on board with this and doesn't want to take place or, be involved in it, they still want to help their patients, right? And so what you tend to see is that hospice referrals go up, palliative care referrals go up, the in-hospital deaths drop, which if you take a survey, most people want to die at home, but in our country, most people die in a hospital. That is not the case in Oregon. And then violent suicide among hospice patients pretty much disappears. This is the article that basically stated that was in the New England Journal of Medicine that really, really spoke to the heart of those statistics. So what have I learned from Hawaii? And I'm going to share I call it my good, the bad, and the ugly, because there's a lot of challenges. And I have to be honest about that, of this law, especially on a rural island. I would think any place generally that's rural, but especially a little island sitting out in the middle of the Pacific. So the good, I'm going to tell you the best thing that I have gotten out of this is my connection with my patients. You can't go through this process with a patient and not really go deep, okay? Really get connected and really get to know that person and their wishes. So that's the biggest good. But the other thing that I just want to mention that I also think that's really good, it came out of coronavirus, which, how many of us can find, when I try to find some good things in it, but it's telemedicine. So, I've used telemedicine pretty much all of my career, never with medical aid in dying. Again, I only had one patient the first year. But in the law, it does state you could do the mental health evaluation with telemedicine, but it doesn't really address the consulting physician or the attending physician. And just by practice, that had always been in person. And then comes a pandemic, right? And can you imagine trying to get a patient that is terminally ill in to see their doctor? And especially if there aren't a whole lot of doctors on the island, maybe me and one other, that are doing this. If I've got a patient all the way south, to get them up here to see me 2.5 hours away. So I got a request I think the pandemic had just started and I was stuck in Florida of all places. And I was working in an emergency department there because they really needed help. And I didn't know when I was going to be able to get back to Hawaii. And I got a phone call, basically that North Hawaii Hospice had referred a patient and the primary care doctor was referring the patient and the end-of-life doula was referring the patient. And could I help this patient? And I'm like, I am 7,000 miles away, but I do know that we can use telemedicine. I know now because of the CARES Act, I know that the Department of Health had made that clear that every piece of the puzzle of MAID could be done through telemedicine. And I have to say, I was a little bit skeptical. I was, I, how can I say this? I am all about connection, and I don't mean just via uh, internet, right? This is deep work. These are deep conversations, and I just wasn't convinced that I could do that through a screen. I have to say that I was pleasantly surprised that I was able to maybe even connect even deeper, because what I realized is the patient's in the comfort of their own home. I'm in the comfort of my own home. Some barriers kind of drop, and you can actually get even deeper in some of the questions that you ask. Not to mention, there's no risk of any transmission. So there's no driving. So I think what's come out of this has been awesome. I hope we are able to continue to access telemedicine, not only for MAID, but other parts of medicine in general. Okay, so what's the bad? So I've told you about the good. What's the bad? Well, I'd say the bad are the barriers, and there's lots of barriers. I've told you about some just that are inherent to the process in general, right? Can the patient be a barrier? Absolutely. So if a patient's not educated in this, what I have found is they make an assumption. They make an assumption that, oh, I can just get this pill anytime I want. It's not a pill, like I've told you, but two, it's a process. So making sure that the patient understands they've got to go through a lengthy process. So that's the education piece. That's the same for physicians. You would be surprised how many physicians on our island don't even know that this is an actual law. So they haven't been educated in it. If a patient hasn't asked them, why would they? They're busy. We don't have a lot, right? That is a barrier, and that's one of the changes that the Department of Health is hoping that our legislature will tap into. What about hospice? Can hospice be a barrier? Yeah, of course, any system can be a barrier, but you know, when a patient goes into hospice, they're going under the care of a medical physician. If a hospice is not at least allowing their physicians to be consulting doctors, that becomes a barrier. That means the patient's got to go outside of that system. And when this started, I can tell you, my understanding was all hospices were pretty much just kind of off, like not going to really touch this. And what I've seen change is that's not the case anymore. So Kona of Hospice has been amazing. Their physician has been willing to be the consulting doctor. So that takes away that barrier. North Hawaii is on a case-by-case basis. And unfortunately, Hilo doesn't allow that. So that is a barrier for patients that are on that side of the island. What about the hospital system? Can the hospital system be a barrier? Absolutely. Just if they're a system, just like hospice is a system, just like a physician is a system, right? And so if there aren't policies in place that are clear, and I'm going to give you an example of how that happened to one of my patients, then they can be a barrier. Pharmacies are certainly a barrier. People think, oh, I can just walk into Long's. This is not a medication you can get at a normal pharmacy. It has to be a compounded pharmacy. And we only have one of those on our island. And I think they are coming around and are going to be willing to compound that medication, but I have yet seen that. So all of my patients have had to have their medication shipped from Oahu. So that actually extends the process that becomes a barrier. Finances. Okay. So if a patient has to pay for this out of pocket because their doctor that does take their insurance is not doing this, right, then of course that can become a financial burden. Because think about it, you've got 3 clinicians you've got to see: the attending, the consulting, and the mental health provider, and you've got to pay for the medication, right? And then the actual act of taking the medication. And I don't think this gets talked about a lot. And I'll talk about it a little bit more when I talk to you about a patient that actually went through the entire process. But if that piece is not being supported by education and presence, that can very much be a barrier. So this is one example of the bad gone good, I'd like to say. So on the left is actually a diagram of a big hospital systems process. So if you're within a big hospital system like Kaiser, guess what? You've got somebody that's being paid to do all of this, and that's wonderful. If you're on a rural island outside of a big system, can you imagine how daunting that might be for a physician who's only going to do maybe one a year? So the process in general, we know it can be complicated. It's not impossible, but unless you've done it before, it does seem a little bit overwhelming. So I want to tell you about my patient. I call him the captain. And I am not even sure how his wife found me, but I get a phone call and it basically said, listen, my husband is dying. He is in hospice and his doctor actually wants to help him, but he can't. The hospital has a policy against going through the process of medical aid and dying. Can you please help him? Well, I happen to work within that hospital system. So I had never seen a policy. I had actually asked for it. So I asked questions. So of course I'm going to help the patient. And I knew I needed to start the process right then that day, because just from listening to his wife, I had a feeling he was one of those patients that might not even make it through the process. So we started it. We did it via telemedicine. I've done all 4 in this year via telemedicine to at least start the process. And I'll never forget him saying to me, he goes, so what you're telling me, doctor, is I just have to stay alive and I have to stay sane. And I said, well, yeah, basically, if you really want to be able to access this, yeah, that's the case. And he did. This was really, really important to him on levels that I can't probably even understand, but it was. And so then I started asking questions. Well, maybe his doctor could be the consulting, right? I'll do the attending if he's already got this specialist in place. And so I start asking questions of the hospital. No, they can't be the consulting. And I went, well, where's that policy? Come to find out, the hospital actually didn't have a policy. They were confusing a policy with taking medication in the hospital, right? Which is a normal policy that most hospitals have. You can't do that because it's a public space. But the system actually didn't have a policy against it at all. And what I want to say about that is they had an opportunity to shift that and they took it. I'm so proud of my hospital, to be honest with you, because they listened to the captain's story. They listened to how he fell through the cracks. They listened to this bad experience and they said, no, we're not going to let that happen to another patient. And so that system has put out a policy. Interesting enough, it just went through today, which is going to allow now all the hospitals that fall underneath that system to make their own policies. And Kona has decided that they will make a neutrally engaged policy. So their clinicians can decide yes or no. Okay. What I want to tell you about the captain is he made it to day 20. We did our telemedicine video and it was, God, he was so weak and he could barely get off. I don't even know if he could get off the couch barely at that point. And it was like we were kind of high-fiving through the screen, but he was so proud that he had made it, that he was going to actually get to access this medication. And then he fell. The day I could legally write his prescription, he fell, he hit his head. Some of the last words to his wife were, what is today and when will I get my medication? And then he died. He died without the meds. And he died a very peaceful death. I have no doubt. There's no doubt in my mind. He had the love of his wife and he had the support of hospice. But he didn't have what he had asked for. And so I am really grateful to the system, to Kona, for actually taking this on and making it so other people won't go through this. The other thing they've done, which I found incredible, and this goes back to what happens when these laws get enacted, is they're not just focused on medical aid and dying patients. They've got a whole team, and I sit on it. We have this committee called the Circle of Life, which we've got some amazing nurses that have really spearheaded this. And basically it's addressing traumatic issues, end of life issues, bereavement, doing it for our staff and doing it for our community. So the captain was a catalyst. Other patients in our community have been a catalyst. And I think that's how you make change. I think when patients tell their stories, even if they are good, even if they are bad, and even if they are ugly, which is the next case I want to tell you about. I call this the Dr. Benadryl case. And this was, so far in my career, probably one of the most aggravating, toughest cases I've ever dealt with. And I am an emergency physician, so I deal with a lot, just FYI. But I got a phone call from the state director of Compassion and Choices. And when she doesn't ever call my cell phone. So when she calls, I'm like, oh my God, something's wrong. And it was, Dr. Charfen, we have this case and it's on your island, and I hope to God you can help. This patient was just told by his doctor that after the patient had gone through what he thought was the whole process, this patient had a primary care physician on the east side of the island that he'd had for years. He had been given a terminal diagnosis. He had gone to his doctor and expressed his concerns about this, and his doctor had told him, I'll do everything I can to help you. And that patient understood that to mean medical aid in dying. So he gave what he thought was his first oral request. He went out on his own, talked to his specialist, got his consulting doctor to sign off. He went and found a mental health provider on his own. No patient ever does that. He did. And then he went back 20 days later to talk to his primary care doctor and say, okay, I'm here to make my second oral request. And I think he called it the Death with Dignity Act, that Medical Aid in Dying Act. And his doctor went, whoa, no. I don't do that. And what I suggest to you is you either go home and die naturally, or you go take a bottle of Benadryl. That will stop your heart. And when I heard this, I actually didn't believe it. I couldn't grasp the idea that a physician had said that there must be some mistake. And so I said, let me call that patient right now. And he confirmed what I had been told and said, and I even had a witness. And I thought, oh my God. But what struck me even worse was when my patient Gary said, so Dr. Charfen, is that true? If I go drink a bottle of Benadryl or take a bottle of Benadryl, will I have a peaceful death? Like my doctor said. And I was dumbfounded. I said, no, Gary, please don't do that. Okay. As an emergency physician, I can solemnly swear to you that taking a bottle of Benadryl is not a peaceful death. If you're going to die at all, I don't know that you would, but it would take several days. You'll become psychotic. You'll become deranged. It won't be pleasant and it could be painful. Please don't take that advice. And I'm sorry you were given that. Okay. That was the start of the ugly. Now, his process, and this isn't ugly. This was just part of the education piece. I have been told he'd had all these pieces in place. Well, in fact, yes, he'd seen his doctor, his consulting doctor. Yes, he'd seen his mental health provider, but they hadn't filled out the forms. They didn't know. And so that prolonged even more waiting and more frustration for Gary. What I will say, though, is his physicians and his mental health provider they called me personally to make sure that they got it right. They didn't know, and they were so apologetic. And Gary was really grateful for that because he hadn't had a lot of support along the way. Gary was, how can I say, I'm going to, as he would say, give you the lead in on Gary. Because Gary had an ugly time with this process, but Gary was an amazing human. And if he would tell you the things he'd want to be most remembered for, was that he was a good father and that he loved his daughter, his 13-year-old daughter, more than he loved life itself. And so if you can imagine somebody that's terminal trying to go through this process and having a 13-year-old, some of my best memories of Gary were him talking about his daughter and her being a straight A student and how proud he was of her. Gary was a provider for her mother and for that daughter. Gary was a friend, and Gary was very proud to be of Cherokee descent from the Wolf Clan. So Gary was a human. Okay, Gary wasn't just a number. Gary wasn't just a story that I can tell you. Gary he became a good friend. And what I will tell you is, even though Gary's story started out pretty ugly, Gary ended up with a lot of support around him. He actually accepted end-of-life doulas, which I introduced that concept to him. He was a little like, what the heck are you talking about, Dr. Charfen? But he ended up with two amazing women that were local, because I lived 2.5 hours from Gary. So I hadn't even met Gary physically when we started this whole process. So luckily he had local end-of-life doulas that came on board. I encouraged hospice. It took me a month to convince Gary of going on hospice because he'd had not a great experience before, and he did. And then it got off. So we had to go with the flow with Gary. And I'm not going to say it was easy, but it was absolutely one of the most rewarding things I've ever done. And Gary said to me, hey, Dr. Charfen, I know you've got to keep this patient doctor line, but he said, I'd really, really love to meet you. before I die. And that was all I needed to hear. So I got in my car and I drove, well, a couple of days later, 2.5 hours with my daughter to meet Gary. And I had a lovely, lovely afternoon underneath Gary's carport, just really talking story, talking about his life, talking about his things he regretted, talking about the things that he just loved the most, which was his daughter. And that's when he told me, he said, Dr. Charfen, I've chosen a date. And I said, wow, okay. He was the first patient that had ever said this to me. And he said, it's 2 weeks from today, and I'd like you to be there. Now, I've always told my patients that I would be there if they wanted me. Okay. But he was the first person that ever took me up on it. He was the first patient that ever actually went through the entire process. And of course I said, yes, I'll make sure my schedule is clear for you. And he said, I want my 2 doulas there, and I just want my family there. And I'm just going to tell you a little bit about what that day was like, because I think it's important. It's the piece that I don't think when I've gone to talks and listened to people actually really heard so much about. It's what is it like? What is that day like? Now, again, remember, Gary wasn't on hospice anymore when he chose to access the medication. And that to me that was concerning, because I knew that they couldn't be there for the process, but they can be there after you die. And I knew that would help his family. The police wouldn't have to be called. I mean, there were a lot of logistical things that I thought about, but again, his choice. So I prepared with my 2 doulas. We show up and it's a party. When I walked in, he had this fabulous hat on, and he's sitting there with his friend, and I hear him telling his story, and he's showing him the article that was put out by the Hawaii Tribune. And he was so proud of that. When it came time for his, because he had a timeline, he actually told me I was late. I was so glad I was there, because Gary couldn't see anymore. Everything was a blur for him. How he was going to mix that medication was beyond me. I saw so many places where it could have gone really wrong. He could have vomited. He could have gotten the medication mixed up. So one thing that I would say to people listening is, especially if this is something you're considering, or you're a physician or provider, just even talking to somebody about this, is this piece that not a lot of people talk about. How are they going to be supported during this piece of that puzzle? And so I was grateful to be there. Gary had a very peaceful death. On his own terms. One of the things he did was raise his cup and said, "Beam me up, Scotty." That was Gary for you. But he fell asleep within about 8 minutes, and he died within 70 in the arms of his lady, as he called her. So that was actually, that ugly turned into something I'm going to say was quite beautiful, even though it was painful. Okay. What happened afterwards was a little scary, because now I had to call the police. I had to call EMS, because he was not on hospice. And there was a point in time I thought I might get arrested. Luckily, I didn't, because the police were very respectful, and they were curious, but they didn't know about the law. They had never heard of this law. They didn't know it was legal. They had never been on a call. So I saw them Googling it. And I'm like, oh my God, there's so much room for education. And that's what Gary did. He educated until he died. He's still educating, I believe. And so I will say that if I leave you with anything tonight, it's that your words do matter. How we speak about end of life care in general, how we speak about life. There's no room for guilt or shame. Okay. This is a picture that was taken by one of Gary's beautiful end of life doulas a week after his death. Something Gary told us was, I'm going to be with you guys. I'm going to connect. Look to the clouds. That's where you're going to find me, in the clouds. And 1 week to the time of his death, 5:40 p.m., this was in the clouds, this heart among this storm. And that's what Gary was to me. He was this big ball of love, surrounded by a lot of drama and a lot of difficult things. But in the end, it ended up being something so absolutely beautiful. So I'm going to end there with my part of the presentation, and just going to take questions. And I see there are several. So let's see. Doctors I work with in Southern California prefer a drug called NT. medication. Your ideas on this NT. So I'll just tell you, I don't know what NT is. There are, so the D-DMA is actually what most physicians in California would be using because most of the data comes out of California. That we know that there is also something else that has, I think it was called D-D. I'm going to mess it up, so I'm not even going to try to tell you, but there was another version of that prior that had propranolol in it. We found that those deaths ended up being extended. Initially, when this law first went into effect, there was a drug called secobarbital or Seconal. A lot of people may be familiar with that. That was the go-to drug for a very long time, but that's no longer available. And that's why these compounded medications started becoming available. That medication went from costing a couple of $100s up to $3,000 too. Oh, that's one thing I didn't mention to you guys. The medication itself is, if you're paying out of pocket, is about $450 to $500. If the patient has life insurance, will it still pay out if they are basically committing suicide? So again, just to make sure you're clear on this, they're not committing suicide under the law. This is not considered suicide. So that's not where life insurance. So I'm sorry, you're saying life insurance, and in the law, yes, life insurance will pay out. It is strictly in the law that they can't not. So you don't have to be worried about that. What happens if, oh, this is a great question. What happens if the patient were to vomit the medication, right? This is, I think is, it's a really reasonable question, and it's a really reasonable fear. And that is why we pre-medicate with a standard dose of medication. If I were to have a patient that was already having GI issues, right? So this is where that really understanding how these medications work comes into play, and why you need to be working with a physician that understands the pieces to this puzzle. So if I had a patient that I already knew was vomiting a good bit, right? Or they had that GI issue, what I would consider doing is using a rectal tube and giving the medication in the rectum to avoid that. That'd be one option. And of course, that's the patient's option, right? Whether they want to go that route. But that's one way if a patient's already in that state. But let's just say, oh gosh, they're just having some nausea. And that was a big concern for Gary. Again, these medications don't taste good either. The first bottle, not so bad. That second one does. So I actually, and when I give even more than what the standard list says to give, just because I want to try to avoid that. And sometimes you can't. Probably what would happen, or I know cases of this. So they take that first bottle. That's not the bottle that probably is the one you have to worry about as much. That's the one that has the digoxin in it. But then what if they go on to take that second bottle and they can't get it down, or they vomit part of it up? It is such a large dose. I listed it, but it's such mega doses of that medication. You will get some absorption, but you need to really be prepared for that. Could it be a prolonged death? And we don't really want those, but they do happen. And how do you prepare the family for that? That's why I think clinicians need to be there. Because I think you can really kind of talk somebody through that and let them know they're not suffering. The other option that I think is really important, and this is where hospice is really important, and if they're not willing to do it, there needs to be a backup plan, is hospices do something called palliative sedation. That's part of their standard practice. And that is medicating a patient to basically putting them to sleep. And so if we had somebody that vomited partially that was having a prolonged death, we'd want to be able to access that. So I know like Cone of Hospice would do that. And if I had a patient that a hospice didn't feel comfortable doing that, that's something I would make sure that I had access to help that patient. That's part of what I have them sign. But again, I've only had actually now 2 patients that have gone through that process. Do nurse practitioners have prescriptive authority for this process? No, they do not. But that is actually up before the legislature. I actually went, I guess it was the beginning of the year because it was before the pandemic hit. So I'll tell you about the 3 things that are up for before the legislature right now. So because of the limited access to physicians and because there are so few physicians on our island or that are participating in it, that's a barrier. And the Department of Health absolutely recognized that. They brought all the physicians that had ever prescribed in 2019 together and said, okay, how can we make this law better? And that was one of the things that came out of that was we need to allow advanced nurse practitioners to participate. Hawaii as a state has embraced them for years. They do primary care. They do end-of-life care. They have prescriptive authority. So why aren't they allowed to do this? So that is before the legislature, and we will be the first state to pass that if that does pass. The other two things that are before the legislature, well, they were this year and they'll go back again because the pandemic messed it up, are decreasing the waiting period to 15 days, okay? And actually doing something that Oregon does, which is waiving the waiting period if an attending physician believes that the patient's not going to make it through that 20-day period or that 15-day period, whatever it may be. Oregon is the only other state that's allowed this. And I went before the legislature and I testified in favor of all of it. But the waiving period was just kind of a theoretical thing for me. I hadn't experienced that. Well, the captain was a perfect example of a person I would have waived. Everybody else that I've seen, I knew they had enough time to get through the process. The captain was that one that I said, I don't think he will. And actually he didn't. Could you elaborate with the barrier experienced with Helos hospice? Well, if you're speaking specifically about Gary, that was his own choice. He had been in, and I'll just tell you a little bit. I don't want to go into all that detail, but he had, prior to meeting me, he had actually been referred to Hilo Hospice. And so he had been with them, I don't remember how many months, but he ended up getting out for his own reasons that had to do around his pain control, because he was in pain management prior to them and there were some issues there. So when he came into my practice, right, several months later, the first thing I'm going to do is recommend hospice. And he was within the Hilo Hospice area. And I reached out to them. I talked to them. I knew their policy because they don't participate. And when I say that, I don't mean that they always support their patients and they support their wishes. But what they don't do, and you can see this on their website, I'm not saying anything that's not common knowledge, I don't think, is they don't allow their nurses to be present with the patient when they choose to take the medication or take the medications to them. And they don't allow their doctors to prescribe at all. That wasn't his barrier. He could have lived through that piece of the barrier. It was his personality, and it just didn't jive with I think the things that were coming down from up above. He loved his hospice nurse, and I even spoke with his hospice nurse. He was absolutely grateful for everything that his hospice nurse did for him. So I don't want to portray it as that specifically was a barrier to the medical aid and dying process. It wasn't, because we already had plenty. We had already kind of shifted around all of that. But I think that does go to another question that I got via email, and I'll just go ahead and answer that. It was like, why would a hospice not be involved in this law? Isn't it law? And I will just tell you what I've heard from different hospices, specific on our island and then in other places. So the mission of hospice in general is not to hasten death. Okay, that's a part of their mission statement. Is they're really there to provide a holistic way of dying, right? And so some stances that hospices take, and I believe Hilo of Hospice does, not necessarily North Hawaii or Kona, but other hospices in the country say, we're not going to do anything to hasten death. So therefore, we're not going to allow our physicians to participate. Meaning they can't be attending. I get that part. They can't be consulting. I really don't get that piece, because being a consulting physician, you're not hastening anyone's death. You're basically just saying that they meet criteria. So that actually decreases the barrier. So that's some stances that they take about medical aid and dying. But I would just say the counter to that is, well, actually hospice in a way does sometimes hasten death. And what I mean by that is they do palliative sedation. Those drugs don't stop somebody's heart, but they do put them in a deep sleep. And that means they don't eat or drink. And so that means that their death is hastened. So I see that as kind of, they're not the same thing, but they are similar as far as hastening. Also, they accept patients onto hospice that choose VSED or voluntary stop eating and drinking. And they allow their nurses to be present for all of that. That's legal in every state. So anyway, that's one stance that I've heard from hospices. The other one, and I can identify with this, is they don't want to put their nurses in a position where they may be compromised. What if, let's say, for example, a patient's family, in the heat of everything, let's say they're vomiting or they're having a hard time drinking and they turn the cup up for them. That's technically breaking the law, right? And so they don't want their nurses in that position. And I understand that. What I would say, the way I'd approach it, and the way I have to approach it, would be, you just need to be, it's education again. If I were walking into the room, we'd need to get very clear. These are the things we do. These are the things we can't do. So I hope that answers. Oh, one other thing I'll say though, to that question is a good place, a good resource when you're talking about hospices and to kind of get an idea and to kind of get feedback and understanding where these different hospices are coming from is acmaid.org, acmaid.org. They have a CME, and I encourage all physicians, clinicians to watch it. It's free and you get CME. But it's a conference. It's a medical aid in dying conference. And one of the first panelists on there are all different hospices. And you can hear their points of view, why they have engaged, why they haven't. Some started off fully engaged and then they kind of stepped back because it became too much work for their physicians. So there's a lot of reasons behind it, I guess, is what I will say. Let's see. Hilo's hospice has changed to a palliative role, and was this part of the barrier? Well, so from what I understand, Hilo has, a couple of things. So Hilo does, this is really wonderful. And this is something that I'm glad they have. They do have actually a palliative care type program that people can qualify for, and they don't necessarily have to be in hospice. My goal would be in our community across this entire island is to have a community-based palliative care role. That means you could get into that way before you could get into hospice, and not necessarily it have to be inpatient. So that's something that I think is a real positive that they have. I don't believe that's a barrier. What I do think could be a barrier, and from how I understand it over in the Hilo, is they're absolutely full. So I had one patient that was on a waiting list, and she wasn't a medical aid and dying patient. She was just an elderly patient that was dying. And because she wasn't dying as quickly as some of the other patients, they had to do a triage. They had to go through and really try to take the patients that were imminent. And she ended up dying off hospice. So I do know that Hilo has been at capacity, and I can only speculate why that is, because typically it's the other way around, really. Typically we're saying, God, people don't get into hospice soon enough. I think the pandemic may have shifted that. Okay. I think people are actually being a lot more thoughtful about their death and what they want and what they don't want. So that's a good thing. But when a hospice gets maxed out, that's, how do we help support them? So I'm not picking on Hilo Hospice. I actually, I think it's incredible that they're able to support as many patients as they're supporting. And that's what we want to be able to do as a community. We have 3 hospices on our islands, and they each have their own territory, and they all have their own policy, and they all do it a little bit different. But if you've ever connected with hospice, okay, whether that's you volunteer or you've had a patient in hospice, I think most of you would probably say that hospice nurses by far are angels, right? So I admire everything that they do. So I want to make sure that's clear. All right. This is a great question. Do you have any personal struggles with the process, or was it surreal to have your patient go through the entire process? Yeah. Okay. I think this is an absolutely excellent question, and I've gotten asked this several times. A personal struggle. I had how can I say it? I had a really deep talk with myself prior to going through the first process. I will tell you, the first time I got asked to take somebody through the process, I cried. And I think I cried for a couple of reasons. One, I was like, oh my God, it's really happening. People are really asking. 2, I was like, wow, I've got to really make a decision. And how do I feel about this decision? And 3, my heart hurt for the guy because his doctors had basically said, I can't help you. Everybody he had turned to said, I can't help you. So my struggle was a little bit initially. I would say that I initially had to really go, okay, how do I feel about this ethically, morally? And I would suggest anybody that ever writes a prescription should do that way before you get a patient that asks. Okay. Like Larry asking me. I mean, I feel like I was guided along this path. I had time to really digest it. It didn't really kind of come out of the blue for me, but I can imagine for Dr. Benadryl, it probably did. Right. So I did have those struggles just kind of theoretically. When I took my first patient through the process, I thought it was going to be a big deal when I wrote the prescription. I remember I was like, oh my God, what's it going to be like to finally write that first prescription? And I'll tell you, going through that entire process, it was actually quite easy because the process is so involved. I get to know the patients. I get to know their reasons. I get to know that this is all them. Right. And so what I guess in part of that goes back to my training as an emergency physician. I may not agree with somebody's choices, but I'm not their judge, right? I am their support system. And the last thing I'm going to do is make them feel bad. And, I'm going to ask questions. I'm going to dig deep. But that was probably where my struggle was. Now, when it came to actually the medication, I will tell you, I built it up. I thought, oh my goodness, what is this going to be like? What is this process going to be like? Am I going to feel guilt about being involved? So I did. I went through all of that. And I will tell you, the day I got there, it just kind of all left as soon as I saw Gary's face. And sat there, and he, and of course, I don't know how many times I said to him, you can always change your mind, because of course every patient can change their mind. Right. But when I helped him through that process, I was so grateful to be there. I'm going to tell you, it was a level of, I was honored. I mean, I felt like I was really in a special place that not many people get to be. So yes, there was struggle, but at the end of the day, I felt like I really helped him, and I helped that process be peaceful. And I'm just going to leave it with this was years ago. I got asked by, I don't know, somebody asked me, what's my favorite thing about being an emergency physician? And I didn't think about it. Just, it shot out of my mouth way before I was into really doing anything outside of the ER in the end of life world. And I just said, my favorite thing, the thing that gives me the most joy, is being with somebody and helping them have a peaceful death. And my husband at the time, I'm no longer married to him, just looked at me and was like, you can't say that. You can't say that out loud. And I was like, why? Because it's true. I don't get me wrong. I love saving people's lives. I mean, there's an adrenaline rush. There is a satisfaction as long as they wanted their life saved. But we do so many things in medicine that go against the wishes of people because they've never made their wishes clear. Somebody going through the medical aid and dying process has made their wishes very, very clear. Okay, I'm going to stop talking because I see more questions. All right. Do you need additional mental health providers to work with this program should the patient not have mental health resources? My God, yes, we need more. We need way more mental health providers. I have been fortunate that I got referred to one specific physician, and she has been incredible. And when I've said my patient needs you now, he can't wait 2 weeks, she's helped. But that's a struggle for a lot of patients, not just on our island. So absolutely, we need more mental health providers. We need more mental health providers in general. And I know that's even because of the trauma that's happened with this pandemic. We need more because the mental health issues on this island are only getting worse. And I see that every time I walk into an emergency department. So for MAID and for the general population, we need more. Okay, wonderful presentation. Thank you. Is there room for a case management role that would ensure the end of life choices? How could I help as a retired APRN? Oh, thank you. Thank you. Thank you. Reach out, info@ldwellness.org, and we'll keep that conversation going. But absolutely, there is a role. So in a perfect world, and I'm just going to use Kaiser as an example, they have something called a patient navigator. So that can be an APRN, that can be a social worker, but that is somebody that takes on the role of absolutely understanding this process in and out. So that doctor over there and that doctor over there and that doctor over there doesn't have to figure it out. So that's in a perfect world, right? And so within a big system that takes this on, that's the best case scenario. But we don't live in that perfect system, unfortunately, on our island. So our Kaiser patients get this. Anybody else doesn't. So I've been, now that I've gone through this in my 5-time experience, it doesn't mean I'm an expert by any means, but it just gets my brain going. How can we help? What are some of the other things we can do? And I don't know if that fits within our nonprofit as a grant and creating this, because there are so many barriers. So please reach out to the Life and Death Wellness, please. I'm happy to continue that, because I really feel like doulas have a role. I'm trained doulas in this field, but they need specific training in medical aid and dying, right? And I think absolutely APRNs have a role. Could you share what you think makes you so compassionate and caring about end of life? Oh, thank you. Yeah. God, how long do you have? We're over time. I wasn't always this way. I was like a lot of doctors for a long time. I was overworked and I was burned out. And I was traumatized by our system. But something I always did well was being with patients at the end of their life. And I believe my emergency training did that for me. But truly, it's my patients. I tapped into a few patients at the end of their life. One's named Kathy, one's named Rhonda. Her death day is today. That really opens me up to another way of being. And that is in life. And that is as a human, not just as a doctor. And so I could tell you a million stories. Read my book whenever I finish it. But I'll tell you, always, my greatest teachers are my patients. And that is, I think, how I have become, as you described, compassionate, caring. So thank you. Thank you for that. And we are over. And so I'm going to leave you with Gary. So I will tell you, on his death day, the day he decided he was going to take his medication, he wanted it filmed. I didn't know how I felt about that. That was a little weird for me. But he didn't want to have his story filmed. He told me, "You're the lead in. Where's your paperwork? You need to tell my story." I'm like, "I've told your story a million times and I'm telling it again tonight." Right. But he really, he wanted, how can I say this? He, at the end of his life, was so grateful for having support, and he wanted everybody else to have that. And he wanted people not to suffer like he did. He made me promise him that I would not let, if it was within my power, somebody go through what he did. And I swore to that promise. But listen closely, because his voice is high pitched.
My name is Gary, and I'm the one that got this thing processed through for me. I had more trouble than I've had anything with my life. Yeah. Go to this place and get hold of some of my papers and stuff we have, you'll be able to see. And you can go to Life and Death Wellness.org. Life and Death Wellness.org. All right, everybody, you got that? I'm counting on you. Now I want you to think about it and help people. And if somebody's out there to see the way, that you maybe start donating a little money to make it easier for these older people. Older people ain't got much enough, and they need to be helped. I mean, jump in and help them. Don't be so cheap with everything. Help the damn people. Thank you.
I think you could say Gary was a card, and I had so much fun with him. And I miss him. I do. But I think you can also see Gary was really, he shared his story publicly, and that's hard. He really had a heart of gold, and he really appreciated people that helped him. And he wants that. He wanted that for everybody. So we do need support. We do need money, of course. And you can make a donation, but we also do need help, and we do need volunteers. We really want to grow this nonprofit organization so that we are continuing our mission of educating and supporting and trying to fill in those gaps that we have on our island. So thank you for listening. This is recorded. You guys will get a follow-up email. Reach out, info@lifeanddeathwellness.org. You can go on our website too, but please join our mailing list. That's how you'll find out what's coming up next. Our next talk is going to be in January. We don't have a date yet, but I believe that will be Bobby Bryant. She's going to have an amazing presentation about community caring for their own. And she is a magnificent end-of-life doula. So anyway, happy holidays. This is Birthmas month for me, which is my birthday this month. So I just thank you all for being here. And that's it. Oops, sorry. I'm gonna, I think, stop sharing and end this presentation. Thank you. Have a great night.